Dr. Ashwanth Narayan. I'm a fellow of Dr. Arun Kannan, sir. So today we have a case presentation of a complex femoral revision. So a 50-year-old female who's an uncontrolled CKD on dialysis, status post bilateral nephrectomy done in 2019 and 20, and known hypertensive for 5 years. So initially she had a fall in at her home and had a neck of femur fracture, which was operated elsewhere in Nellore. I'm sorry about the X-ray quality. That is all we have, sir. Um,
Okay, sir.
so, in Nellore, they have done unsymmetric bipolar hemiarthroplasty. And this is the post-op X-ray, and the right one is the 10 days post-op. So here we will be able to visualize the subsidence from the level of the GT. This just the 10 days post-op picture compared with the immediate post-op picture. So for this, after 1 month, they have revised it with the unipolar processes and mesh and cerclage wire. So later, patient presented to us about 1 year, 4 months later to our OPD, but patient presented with the opposite hip pain with no history of trauma. Patient also had pain in the anterolateral thigh of the left femur. So patient was also found to have elevated parathyroid hormone, alkaline phosphatase, creatinine, and patient was diagnosed to have a metabolic bone disease associated with the prolonged CKD on dialysis. Okay, so the patient was also diagnosed to have a metabolic bone disease based on the following values, and the patient also was seen to have a loosening of the unipolar stem and femoral perforation as well. Just a minute, sir. Something wrong with the slide.
What happened, Ashwanth?
I couldn't change the slides. Just a minute.
Yeah, I think basically at this while he brings the slides back, here the lady had a left side the unipolar with the perforation and right side right side femoral neck fracture with metabolic bone disease. So that is what we were looking at. So I mean, any based on the previous thing, maybe Mithun or somebody, Mithun or Bharat, what would you do for the right hip at this stage?
If it's basically if it's CKD, there is the option bipolar we should not do. It can cause protusio, and then here metabolic bone disease is there. Chance for stress fracture is there. So we have to optimize the patient and then improve with the vitamin D and then we should take for surgery, I think.
No. Renal failure is secondary hyperpara.
Okay.
That cannot be thing. And vitamin D is not going to help you.
The endocrinologist.
So if the renal function improves, the hyperpara will stay.
Okay, sir. Okay. Just an improvement of the general condition, then secondary hyperpara. Okay, sir.
Yeah, the secondary. So all renal failures will have secondary hyperpara.
Sir, I mean, will you wait for the metabolic disease to, correct before you do the right hip or?
Certainly not. Yeah, I mean, renal failure will not improve. It will not. I mean, unless they do a transplant or they do something about it, it is not going to improve. That is expected.
Yeah.
So we just have to go ahead do a simulated property. Make sure you do a THR, simulated stem, maybe the thing on the right side.
Yeah, okay. I think Ashwanth, we can go ahead with the next slide. Yeah.
Yes, sir. So, since patient presented with right hip pain without any history of trauma, so to rule out any pathological fractures, we took an MRI and saw. So, in the MRI, it showed the stress fracture of the neck of femur. So, what are the options now, sir?
Yeah, I think we
Either.
already discussed. Yeah, you can go and
Yes.
show what we did. Yeah.
Okay. So 1 week we did a cemented bipolar hemiarthroplasty of right hip, and this is a 1 week post-op picture, sir. Then we started also on treatment for the metabolic bone disease. This is
That was
3
regular
weeks.
dialysis, and they gave, activated form of vitamin D. Plain vitamin D will not work in renal disease because the activation form is not. So we have to give calcitriol in these cases. So they gave prolonged course of calcitriol. I think, sir, THR is an option, but the bone was, I didn't go attempt for a THR. Bone was really bad shape. If at all, I think if you had to do a cup in this, it would have been a cemented cup or a cup depending on screws. So I did put in a bipolar, and that's what we did for this lady. Maybe you can go on for the next
That's
discussion.
fine, Arun, but the principles does not change. We need to do THR, metabolic bone disease, especially in it's not, you're not corrected it or it being corrected, you have to do
price tracking. So
you have to do a
I think that's, yeah, we'll go to the next slide. Next slide, Ashwanth, you can go on.
Yes, sir. So this is a 3 months post-op picture.
Next.
Yes. So 7 months after the right hemiarthroplasty, the right hip was asymptomatic and patient was walking with walker, but the left thigh anterolateral thigh pain was worsening. By the time the metabolic bone disease was under control, we have the parathyroid hormone and alkaline phosphatase levels came to normalcy, and CRP was also found to be normal.
What was the
So
creatinine? What was the creatinine level?
The creatinine goes up and down, sir. I mean, like with the dialysis, it comes down, then it goes up. It was somewhere maintaining between around 3, sir. 3 is, with proper dialysis, around 3. Yeah.
It'll also, even dialysis will control all the metabolic features for sure.
Yeah. Regular dialysis, she was not considered for a transplant because of other issues. But this is what I think. Metabolic bone parameters all came to normal. They gave rocaltrol, which is activated vitamin D, and for a prolonged course, and then it came down to normal levels. So yeah, this was the stage at which we were left wanting. Right side was painless. She was okay with that. So for the left side, what will be the option at this stage? Any options that you would go for cemented long stem? I think most of us would not do a cemented long stem. But uncemented, what would be the way to do an uncemented stem in this? It is perforating until the knee. So how long will we have to go for fixation here?
If the metabolic bone disease is corrected, I wouldn't worry about the perforation so distally. I would put an uncemented stem, and if necessary, I will run a plate on the lateral side. Yeah, that would be my option. I wouldn't certainly try to address the perforation with the stem.
Okay.
How long you will decide the stem length in this case? Two distal.
Yeah, I think this is kind of a custom-made hemi. They do sometimes, and I've seen 2 cases like this from Andhra Pradesh. I think they kind of custom make it and put this stem in. I don't know who makes it for them or what, but I've seen 2 cases from Andhra Pradesh, especially with this kind of stem. And one of my colleagues, he's a friend of mine. He tried to revise a similar stem in Andhra Pradesh. They couldn't get it out from the top. He tried opening from distally, then knee, and a lot of blood loss, and patient ended up. They couldn't take the stem out after a long struggle. That's what I heard. So these are kind of stems that are custom made. You can see there is a hole in the distal part of the stem also for, I don't know what, I think probably putting some interlocking screws.
Reef option like
So
that.
kind of cemented, uncemented hybrid or whatever you can call it. But it was, that's a peculiar thing we had. I think they tried to do an ETO and then femur broke and then they put all this mesh and everything to cover it. So yeah,
whatever you
I think
do,
we did what both are was suggesting. Yeah, Mithun.
you need to augment, I think, sir, whatever option we do with the plate by the sides.
Yeah. I think that's what. Yeah, next slide, please.
So this was the immediate post-op picture of the left femur, and it was 1 year post the right hip surgery. So here we have done a bipolar hemiarthroplasty with a Wagner stem and augmented with circular wires, bone grafting, and a lateral side distal femur plate. So this was the 1 month post-op left femur picture, and we kept her in non-weight bearing for about 1 month and 2 weeks toe touch weight bearing, and then 2 weeks we kept her in partial weight bearing, and after 6 weeks we made her weight bear. So this is a 2 months post-op picture of left femur.
Yeah, looks very good.
This is a 4 months picture, sir. So we took a oblique view to also make sure that it's within the canals.
Okay, I think we can show the final pictures and stuff.
So this is a 7 months post-op left femur picture. The patient was able to do full weight bearing walking for up to 10 minutes and able to climb 15 to 20 steps with support. So this is a clinical picture of patient doing active SLRT in both lower limbs, but the patient had a little weakness in the active hip abduction. So this is a walking video of the patient 7 months post-op. Sir.
Yeah, I think that's yeah. You can close the presentation.
Nice presentation, sir. Excellent. Sir, what do you do if it's suppose if a bisphosphonate induced stress fracture like that situation case? I've seen some cases they are putting rubber stud graft over the fracture site and then augmenting with plate in a similar scenario.
Strut grafts are kind of a little bit out of fashion, I would say, nowadays. I mean, occasionally you can use it, but generally, I mean, they have not given much of stability or osteoinduction with strut grafts. I mean,
Okay, sir. Okay.
do you have nothing else to do, then you can do a strut graft, but I think plates work better in these situations.
30 dana. Nice case, Arun. So, any tips on how did you take it out? Was it easy, difficult?
Yeah, it came out quite easily. I mean, we didn't have to struggle to take it out. It was a fairly smooth stem and it was loose. And luckily, I mean, I didn't have too much trouble taking it out. Just hammered it out from the top and it came out. I think the point is, I think as sir was saying also, if I think sometimes if the perforation is too distal, we should look at plating it and not go for a very long stem trying to bypass the perforation. If we can get a good proximal hold well above that.